Hello everybody, my name is Hans Törnblom and I'm a gastroenterologist residing in Gothenburg, Sweden. To start with, I would like to say thank you so much to the Aldo Torsoli Foundation and Rome Foundation for being selected to receive the 2022 Aldo Torsoli Award. Professor Torsoli and my predecessors as awardees are names that I'm deeply honored to be mentioned alongside. Who am I? Basically, a clinical gastroenterologist deeply involved in translational science among a group of people that I enjoy working and collaborating with, both in Gothenburg but also among many international collaborators. Science really is dependent on being part of good teams, and I'm very happy with the one I belong to. As both a scientist and gastroenterologist, I'm very much still a patient doctor, and what drives me forward is really the quest of helping people with chronic and more or less debilitating symptoms to a better life, whereas many of the initial fears and questions in general should not be found as exhaustive to the doctor. Rather be seen as the most important clue in the patient-doctor relationship in order to end up with a doctor that has made a confident diagnosis, still energetic to keep on helping the patient. Some of my most recent research activities can be helpful to understand what characterizes a patient compared with someone with comparable symptoms but without seeking healthcare. In this slide to the left you can see that the IBS subjects in general are dominated by younger females with a lot of GI symptoms, but notably also with a lot of somatic symptoms in general. Among those who seeks healthcare, you can see that the proportion of males and females are not very much different, but they receive more medications, and the most bothersome symptom are reported as bloating. Among those who receives IBS diagnosis by a doctor, once more the female predominance reappears, and they are having abdominal pain as their most bothersome symptom. Important basics such as the prognosis is also important to be able to convey to the patient. These epidemiologic data are based on the Swedish IBS patient, where we have reported the same life expectancy in IBS as compared to the background population, and in most patients also a declining GI symptom severity over time. But to note, there is some patients that this does not happen to during a 5-year perspective. Factors to keep in mind when assessing a multidimensional clinical picture are that the younger female patient with psychological features are at higher risk to belong to the group with continuing symptom intensity, and therefore perhaps deserves an extra careful follow-up for an optimized treatment plan that also include all aspects of ill health that can contribute to the GI symptoms. This is also important knowledge, at least based on the use of the diagnostic code for IBS in Sweden and the diagnostic yield of an endoscopy after the IBS diagnosis have been set. And as you can see, the diagnostic yield is lower than in the non-IBS background population for important gastroenterological diagnoses that we are looking for by endoscopy, such as IBD, colorectal cancer and precancerous polyps, but notably not for microscopic colitis in the age group above 45 years. Along the same line, having another diagnosis included among the bowel disorders, chronic constipation, does not come with an association with later developing colorectal cancer. These last 4 slides do perhaps not report the most exciting research outcomes, but in the clinical context they are immensely important for the confidence both among doctors and for the message that can be given to reassure patients in, for example, abstaining from an endoscopy in an IBS patient without the risk of missing out on other than perhaps microscopic colitis in a diarrhea predominant situation in the elderly, something that I think most of us already are aware of. Finally, my recent studies linked to the Rome Foundation Global Epidemiology Study and its pilot project, the 3-country survey, can be highlighted by these less recognized diagnostic groups that we have had a look at. I'm convinced that there is a lot to invest in better understanding the 2 to 3% of the adult population that suffers from a chronic nausea and vomiting syndrome or rumination syndrome. These are diagnoses less well recognized by many doctors, perhaps partly due to them being considered as difficult to treat. From what has been described in this presentation until now, many of you have seen that there are a number of clinical aspects that interests me, and among them to better understand how to use our current knowledge of what we previously labeled the functional gastrointestinal disorders, but now instead the disorders of gut-brain interaction, referring to the importance of the bidirectional communication that is going on in the nervous system of the patients. This is an interest that have resulted in a number of educational activities and reviews concerning the use of what I prefer to call neuromodulators in the treatment of GGBIs. This somewhat busy slide sums up a suggestion of how to properly use neuromodulators to treat different aspects of DGBIs, where I would like to stress that many of the included drugs do not traditionally belong to psychiatry, rather are by some forgotten to have important aspects of function related to a peripheral neuromodulatory property. I've also spent time exploring the concept of augmentation, that is, using two or more treatment options in parallel when there is insufficient effect or dosage possibilities of one or more medications due to side effects. Moving on to the core of my research projects and publications, they are related to one or more of the pathophysiologic mechanisms we now link to IBS that are depicted in this slide. My very first attempts were directed to these three areas: inflammation, bacterial flora, and gastrointestinal infection. We started out by reporting signs of enteric neuropathy and lymphocytic immune infiltration in the deeper layers of the jejunum now 20 years ago. We also made an attempt to find differences in the microbiota of the small bowel, comparing health and disease represented by patients with symptoms suggestive of small intestinal bacterial overgrowth, without success using traditional culturing techniques. We also made a follow-up study of a cohort treated for infectious diarrhea and the risk of developing a DGBI, which happened in 12%, but without any clear risk pattern related to the insulting microbe, but still with Campylobacter ending up at the top. And as you can see, the prevalence of DGBI symptoms in this cohort slowly declined over time. Two more pathophysiologic mechanisms were added to my studies, represented by GI motility and GI sensory function, and also how these pathophysiologic mechanisms related to the symptoms that the patients report. This study is important as I see it from many aspects. 1. Most IBS patients have normal or anal transit time. 2. Few patients with IBS and constipation have slow transit constipation. And 3. Almost a third of patients with IBS and diarrhea have accelerated or anal transit time. Among these patients, gut transit was associated with stool form and the frequency of bowel movements, but very little so to other GI symptoms, which is important knowledge when treating the disturbed bowel habit in IBS and what to expect from treatment. Later, this large-scale study confirmed what others already have reported, that about half of the IBS patients are hypersensitive to rectal distension when investigated by the rectal barostat technique, which shows both as a lower sensory threshold, more intense symptoms reported, and larger visuosomatic referral areas compared with health. It is obvious, though, that single mechanisms only explains part of the symptoms patient report. In the same study, we combined the gut sensory function measurements with having a provocation meal and observing the rectal barostat balloon volume for 1 hour after having the meal. And as can be seen in this slide, Those that were defined as hypersensitive have a different rectal motor response to a meal compared to the normal sensitive population, which is a sign of interaction between different pathophysiological mechanisms. And in a recent study still in the publication process, we report that oroanal transit time also affects the symptom response to a meal in patients with IBS. Study outcomes that shows the complexity of interactions where we need to tease out which mechanisms can be manipulated in a way that reduces symptoms and also perhaps reduces the effects of other pathophysiological mechanisms. Furthering the interaction possibilities in the DGBIs by adding mechanisms that probably are of central origin, like stress, psychosocial factors, adverse life events. We've been able to show that there is an additive effect of aberrant findings in different pathophysiological mechanisms on symptom severity and quality of life. That is, if you have 2 or 3 aberrations in these pathophysiological mechanisms, the chances are higher that the symptoms are more intense and the quality of life is lower compared if you only have 1 or perhaps 0 aberrations. Finally, focus today is related to IBS and food. We have reported the importance of diet therapy in IBS, but we have had difficulties in telling the different strategies apart. Like in the uppermost part of this slide showing that both the low FODMAP diet and the traditional IBS diet advice reduced symptom to a similar extent in our study. But we also recently highlighted the importance of addressing the risk of restrictive eating in some patients. That is, that the IBS symptoms can result in eating behaviors that are too restrictive for long-term good health. And as food for thought, in our latest randomized controlled trial comparing short-term effect on IBS symptoms from 2 carbohydrate-restricted diets and optimized medical treatment, all 3 treatments created symptom improvement in many patients, but better so for both diet therapies compared to the optimized medical treatment. But once more, we couldn't tell the 2 diet treatment groups apart. Finally, a few words about a selected number of role models to me during my career as a doctor and scientist up until now. To start with, Lasse Carling, my first clinical mentor who taught me the basics of gastroenterology and endoscopy, but most importantly, he learned that it is allowed to have fun at work, something that I have continued practiced since then. Professor Greger Lindberg was my first scientific supervisor as a PhD student, and he taught me to think outside of the box, but also the importance of caring about those patients that too few care about. During the last 10 years, Professor John Tuck has been of importance. He has shown that over-the-border collaborations do work well, and borders does not really matter anymore to science. John has also given high-speed, high-quality multitasking a face to me. And also Professor Doug Drossman, with whom I've developed my skills in the multidimensional clinical patients characterization and an improved gut feeling of what to call it for the patient with DGBIs. Last but most importantly, my close collaborator and dear friend, Professor Magnus Simren. His importance for DGBI research in Sweden and in general, I think, is immense, including the capacity to build prosperous teams in a friendly environment. And with that, I once more thank the Aldo Torsoli Foundation for the honor of being selected to receive the 2022 Aldo Torsoli Award. Thank you.